Okay, my presentation is about tuberculosis. And first, I'm just going to start off with a brief history of the tuberculosis disease in the United States. Initially, TB didn't have a cure. Victims suffered hemoptysis, that bloody, hacking, coughing fits. They suffered debilitating pain in their lungs and fatigue. It's estimated that 110,000 Americans died each year from TB in the 1900s. And it was sometimes called consumption due to the way it appeared to consume the bodies of those that were infected because they lost weight so rapidly. In 1884, the first TB care facility in the United States was built, the Adirondack Cottage Sanatorium, and by 1938 there were more than 700 sanatoriums open nationwide, and 1 out of every 170 Americans lived in a sanatorium for TB care. October 19th of 1943, Albert Schatz witnesses a strain of Streptomyces bacterium actually destroying the tubercle bacillus, the bacteria that causes the TB, and this would actually be later called streptomycin. And in 1944, the first human trial of streptomycin is administered, and it's proven successful at eliminating the TB bacterium. Tuberculosis is a chronic bacterial infection that's caused by the Mycobacterium tuberculosis, or MTB. MTB is a rod-shaped bacteria that was originally discovered in 1882 by Dr. Robert Koch. MTB is sometimes referred to as Koch's bacillus. MTB is a slow-growing aerobic bacterium that can only live in humans. No other living or non-living thing can carry the MTB bacteria. Tuberculosis is spread from person to person through tiny droplets in the air, and that can happen anytime a person coughs, sneezes, spits, laughs, or even just talks. And there are 2 forms of tuberculosis. There's latent TB, where someone has the bacteria in their body but the disease actually doesn't occur. And then there's TB disease, or active TB. In order for a person to actually develop TB disease, the person has to have the MTB bacteria in their system, and their immune system has to be to a point where it can't fight the bacteria off and the bacteria can then multiply. In the case of latent TB, bacteria is present in the lungs. It's surrounded by macrophages, which contain the infection. The macrophages kind of build off a little wall, and they keep the bacteria in these little pockets called granulomas. And as long as the macrophages are effective at doing that, TB disease will not develop. The granulomas, though, leave small scars in the lungs, and that's sometimes why they do x-rays to check for TB. Granulomas can rupture, and if that happens, fluid leaks into the pleural cavity. It's the space between the lung and the chest wall, and it creates what's known as tuberculosis pleurisy. As fluid in the pleural cavity increases, it causes shortness of breath and chest pain that worsens on inspiration or breathing in. 2/3 of patients who develop tuberculosis pleurisy will develop active TB within 5 years. Bacteria in the lungs of latent TB patients can also reactivate at times when a patient's immune system is compromised. When the bacteria are reactivated, the granulomas begin to break down, and the liquid that they contain goes out into the patient's airways. A cavity forms in the lung, which allows carbon dioxide and oxygen to enter, and in this environment, the TB bacteria grows very rapidly. And this is called cavitary TB. Patients with cavitary TB are very contagious. And again, in order for a person to develop active TB disease, the person has to have the MTB bacterium in their body, and their immune system has to be suppressed so it cannot prevent the TB bacteria from growing and spreading. And this is actually why TB usually affects people with weakened immune systems. There's only about 5 or 10% of people that are infected who don't receive treatment for latent TB that actually will go on to develop TB disease. TB can be fatal, and tuberculosis usually affects the lungs, but can also infect other organs, such as the spine, the kidney, and the brain. In patients with TB disease, the bacteria severely damages the lungs, which causes severe coughing. The patient may cough up blood, and when you have, it's called pulmonary TB if it's in your lungs, of course. The patient can also experience chest pain and shortness of breath. TB infections can also cause fatigue, weight loss, fever, and night sweats, and then hemoptysis. Patients sometimes run a low-grade temperature as well. TB disease can permanently damage the lungs. It can form holes between the lungs and nearby airways, and it can also block airways. TB disease can also be spread to other parts of the body if it's not treated. TB disease can cause tuberculosis arthritis if it spreads to the joints. Typically, if tuberculosis arthritis does occur, it happens in the knees and the hips. TB can also cause meningitis or swelling of the membranes that cover your brain. And because the liver and kidneys filter out waste from your body, TB disease can often affect these organs as well. If TB disease spreads to your liver or kidneys, it could cause blood in your urine. Very rarely, TB disease can also affect the heart, causing inflammation of the tissues that surround your heart. In turn, this can cause fluid buildup around your heart, which can put extra pressure on this organ and interfere with the heart's ability to pump blood effectively. This condition is known as cardiac tamponade, which can also be fatal. The signs and symptoms of tuberculosis disease depend on where in the body the bacterium is found. Pulmonary TB presents with a bad cough that lasts 3 weeks or longer, pain in the chest, and hemoptysis, which again is coughing up blood or blood-tinged sputum. Other symptoms of TB disease include weakness and fatigue, the weight loss we talked about earlier, which is why it's called consumption, the lack of appetite, chills, fever, and night sweats. People with latent TB often don't have any symptoms. The FDA has approved over 20 medications to treat TB disease. Of these 20 medications, the preferred drugs are isoniazid, rifampin, ethambutol, or pyrazinamide. The recommended course of anti-TB agents is 6 to 9 months of medication. The initial phase always lasts for 2 months. The first phase of treatment is isoniazid, rifampin, ethambutol, or pyrazinamide, 1 time a day for 56 days. The second phase of treatment continues for either 4 months up to the full 7 months. Phase 2 can be either isoniazid with rifampin daily for 126 days, or isoniazid with rifampin 2 times a week for 18 weeks, or a total of 36 doses. The second phase for most patients would last 4 months. There are some patients who require the full 7 months of treatment in phase 2. These patients would include any that had cavitary pulmonary TB, caused by the drug-susceptible bacteria, and whose sputum culture after the 2-month treatment is still positive for TB. Any patient whose initial phase of treatment did not include pyrazinamide would also need a full 7 months of treatment in phase 2. In addition, any patient who was treated with once-weekly isoniazid or rifampin and continues to have positive sputum cultures after a full 2 months on medication would also be required to complete the full 7 months of phase 2 treatment. We do actually have 2 types of drug-resistant TB. There's MDR TB, which is multi-drug resistant, and XDR TB, which is extensively drug resistant. MDR TB is resistant to either ionizid or rifampin. In order to be classified as XDR TB, the bacteria must be resistant to both ionizid and rifampin, as well as fluoroquinolone, and at least one of the 3 other drugs that are known as the second-line drugs. The second-line drugs include medications like amikacin, kanamycin, and kepramycin. MDR TB is treated with fluoroquinolone. Bedaquiline fumarate is used to treat both MDR TB and XDR TB. After treatment for TB disease, MDR TB or XDR TB is completed, follow-up sputum samples will be taken to test to make sure the patient no longer has the Mycobacterium tuberculosis bacteria in their body before treatment will be considered to be complete. In order to prevent the spread of TB, of course, we have standard precautions, and that's basically when you're washing your hands, wearing gloves when you're coming into contact with bodily fluids, just the everyday stuff. If you're caring for someone that actually has an active TB infection that's been confirmed, then you're going to have to do the droplet precautions. So wearing proper protective equipment. The patient will have to be under proper ventilation, so they'll have a hood, a tent, or a booth, so any contaminated air can be diluted or removed and handled appropriately so more people don't get sick. And people that are actually caring for people that have an active TB disease needed to be fitted for a NIOSH N95 respirator mask, and that's to protect the healthcare worker from getting TB as well. And I think that's all I have. Thank you so much.